Okay guys, this time we shall be talking about image-based questions that are related to the topic that we have studied, that is cardiology. You can look at the image on the right hand side where this particular blood vessel that is currently being marked by me, this blood vessel is actually the left main coronary artery. And from this left main coronary artery, you have origin of the left circumflex artery which will go posteriorly, and this blood vessel that is marked as 3, this particular blood vessel, this is left anterior descending artery, which if it gets involved then it would result in development of the commonest type of MI, that would be anterior wall MI in the patient. However, in a multiple choice question, if they ask you that the patient is having a extensive anterior wall MI, now if you read the word extensive anterior wall MI, then in extensive anterior wall MI, the blood vessel that is involved happens to be the left main coronary artery of the patient. So do take care of the fact that whether it is given anterior wall or it is extensive anterior wall, because extensive anterior wall MI would be left main coronary artery. This that is shown here are the diagonal branches of the left anterior descending artery, and they will be supplying the lateral surface of the heart. The one that I am marking right now is the right coronary artery. This will supply the right ventricle, and the involvement of this blood vessel would result in development of inferior wall myocardial infarction in the patient. To read these blood vessels, we have this anatomical arrangement. You can notice the fact that lead number V1 and V2, they are mainly to read the area of the septum. So septal MI findings are seen in V1, V2. Whereas V3, V4, V5, or I think V3, V4 I would say, they are more suitable to read the anterior surface. And when it comes to V5, V6, they are more suitable to read the lateral surface of the heart. So you can mentally visualize that these are like CCTV cameras that are monitoring the various surface of the heart. And then lead number V7, V9, they are used to study the posterior surface of the heart. So posterior wall MI is best evaluated with the help of lead number V7, V8, V9. Lateral wall is V5, V6, anterior is V1 to V4 because septum is also anterior, and specifically septal is V1, V2. And how do you identify inferior wall MI? For inferior wall myocardial infarction, I can squeeze in the data here only. For inferior wall MI, the leads that are suitable are lead number 2, lead number 3, and lead number AVF. And especially most of the time, MCQ wise, I would like you to give importance to inferior wall MI because traditionally most examiners would love to ask about it. Vagus nerve usually gets involved in inferior wall MI. So this is the only variety of MI where there would be a bradycardia, because normally traditionally in MI you always have a tachycardia. But inferior wall MI is a bradycardia, so you will be using atropine for management of these patients. And one more fact that I can say from the current diagram is, though it looks a little messy at the moment, is that we are using a special lead that is known as V4R. This is especially to study right ventricular myocardial infarction. This right ventricle is not on right actually. Right ventricle is inferiorly located towards the diaphragm. So a special lead that can be put to study the right ventricle is V4R. This is the chest lead to study the right ventricle. So the anatomical arrangement of the leads is important to identify which surface of the heart is involved. Moving to the next image. A patient collapsed while waiting for boarding an aircraft and was rushed to the medical room. So let me say you are the doctor on duty at the airport and this guy has collapsed and you took out a quick ECG. Now, if you look at the ECG of the patient, you will first notice the fact that in this patient, if you calculate the heart rate, you can see that the number of squares, large squares, which are present between the two R and the R waves are about 3 large squares. Mathematically speaking, if it is 3 large squares separating R and the R waves, then the heart rate of the patient would be something close to 100 per minute. Once you have looked at the heart rate of the patient, you will calculate the axis. For axis, you can see that in lead 1, R wave is bigger than the S wave. So I'm putting a positive word here because R is bigger than S. Then you will look at AVF, and in AVF also you will see that there is a R wave, there is no S wave. The vector for both lead 1 and AVF is positive, which means the fact that the patient is having a normal axis. So heart rate is close to 100, it is normal axis. Then we can look at the P wave in any one of the chest leads of the patient, and if you look at the P wave of the patient looks pretty decent in a sense that this would be about 120 milliseconds or lesser. Even the PR interval looks okay, and the QRS complex duration is also normal. So P wave duration wise is normal. P is always followed by QRS, which means there is a normal sinus rhythm, and these PR interval of the patient is also normal. Now when you cast a glance at lead number 2, you will notice that at lead number 2 you are getting a classical party sign. At lead number 2 you are getting a classical party sign. Lead number 2, lead number 3 and lead number AVF is showing a ST segment elevation. Since 2, 3 and AVF is showing a ST segment elevation, the clinical diagnosis of this patient will be inferior wall MI. Now there are two choices in the MCQ with inferior wall MI. One is saying inferior wall MI with T wave inversion in the precordial lead. Second is saying inferior wall MI with ST elevation. I can see the classical ST elevation. I can see the classical party sign in this particular case. So since I can demonstrate a classical party sign, I can demonstrate this particular ST segment elevation. So the diagnosis of this patient would be given as C, that is inferior wall MI with ST elevation is present in lead number 2, 3 and AVF. A particular type of MI that is being frequently asked in the exam is inferior wall MI, which is due to blockage of the right coronary artery. Points to be remembered for inferior wall MI is that because vagus nerve is involved in this particular MI, this is the only type of MI where you will be encountering vomiting in a patient, because vagus activation will cause reverse peristalsis and will cause vomiting. Second, in inferior wall MI, there will be vagus activation causing a bradycardia, causing a hypotension. In this patient, since there is a right ventricular failure, pulmonary edema will not be encountered in these patients. Traditionally, in anterior wall MI, you always have a crepitation in the chest, but in this case, there would be no pulmonary edema. The best way to identify this MI is to look at values in lead 2, lead 3 and AVF, and you should have is a significant ST segment elevation. The magnitude of ST elevation should be more than 2 mm in males and should be more than 1.5 mm for females. Also remember the fact that whenever we are admitting a patient with acute coronary syndrome, we give 4 things: morphine, oxygen, aspirin and nitrates. Remember the fact that nitrates are contraindicated in hypotension, so you should not give nitrates if the blood pressure on admission is less than 80, and nitrates are contraindicated in inferior wall MI. On admission, in all cases of MI, a beta blocker is given by the name of metoprolol. Metoprolol is also contraindicated in inferior wall myocardial infarction since there is a bradycardia. Then they have asked, what will you give for management of bradycardia of the patient? So for management of the bradycardia, you will be giving atropine. And for management of unrecordable BP in the patient, if it is given unrecordable, you need to increase it to recordable. You will be giving IV fluids to the patient. In traditional MI, you do not give IV fluids to the patient, but in this case, inferior wall MI, IV fluids would be given. So these are points for inferior wall MI that you should be remembering. Moving to the next question, a 65-year-old diabetic presents with extensive sweating and dizziness. The ECG is shown below. What is the diagnosis? If you look at the leads in the patient, especially right away, if you look at lead number 1, you will notice a very peculiar configuration in lead number 1. If I have to calculate the heart rate of this patient, let's just try to calculate the heart rate. I am able to count 1, 2, 3, 4 large squares separating the R and the R waves. So if it is 4 large squares separating the R and the R waves, the heart rate of this patient is close to 75 per minute. If I have to calculate the axis of the patient, you will have to look at the vector for lead 1, where you will subtract the number of small squares of S from R, and this would be positive for lead 1. If you look at AVF, then for AVF I can say that R and S are almost of the equal amplitude, so this would be something close to 0. So lead 1 is positive, this would again be normal axis. Then you are having a ST segment elevation which is present, and this ST segment elevation can be seen in lead 1. Then you can also notice some magnitude of ST elevation coming up with hyperacute T waves in lead number V2, V3, and even V4 is showing the same finding. In fact, at this particular point of time, this pattern that is present here, this is known as tombstone pattern, which is again a very characteristic finding that is seen in patients with myocardial infarction. Since it is a diabetic, he is probably having a silent myocardial infarction, but other symptoms are still present like sweating and dizziness. So the clinical diagnosis of this patient is anterior wall myocardial infarction. Moving to the next question. Remember sudden death in a diabetes, sudden death in a diabetic patient is always to be thought of with silent myocardial infarction. If silent MI is not in the choices, then the second most important cause for sudden death in a diabetic patient should be remembered as hypoglycemic unawareness. Moving on to the next question. You can just follow the tracings here. For myocardial infarction, it would always be a ST segment that will be convex upwards, as you can see on the right hand side. But in this one, if I trace it before you, you can see a concavity. So this concavity is the one which is indicative of diagnosis of acute pericarditis. So both the findings which are mentioned simultaneously are those of ST elevation of pericarditis versus that of Party sign. Causes of ST segment elevation are electrolytes. Electrolytes would mean like hyperkalemia. L would stand for left bundle branch block. E would stand for early repolarization variant. VA would stand for ventricular aneurysm. This is a structural damage that is usually seen post-MI. Left with TION. So T would stand for trauma that could be sustained during pericardiocentesis. I would stand for ischemic injury that would be due to MI. O would be Osborn wave, which would be seen with hypothermia. And N would stand for non-occlusive vasospasm. Non-occlusive vasospasm is the one that is encountered with parenchymal angina. So these are causes of ST segment elevation which are to be remembered by you. ST segment depression. Remember chronic stable angina where there is a 70% blockage in the coronary arteries. Digoxin, hypokalemia, and left ventricular hypertrophy due to any cause. That could be aortic stenosis, it could be hypertrophic cardiomyopathy, it could be hypertension. Those are causes of ST segment depression. In this particular case, you will notice the fact that there is a ST segment elevation in the patient, but this is followed by a T wave inversion. This ST elevation, which is followed by a T wave inversion, is known as Brugada sign. Brugada sign is seen in Brugada syndrome, which is a channelopathy. It is a sodium channel defect and it can contribute to development of sudden cardiac death. Second is hockey stick sign. This hockey stick sign is seen with digoxin. Hockey stick sign is also read by us in literature for MRI. Hockey stick sign in MRI should be remembered for variant Creutzfeldt-Jakob disease. Hockey stick sign is also to be remembered for echo, that would be mitral stenosis. So hockey stick sign is to be remembered for digoxin, not toxicity, right? Digoxin toxicity causes the arrhythmia. The arrhythmia that is caused by digoxin toxicity is ventricular bigeminy. Here you need to remember digoxin administration can cause a ST segment depression. Hockey stick sign on echocardiography is mitral stenosis, and hockey stick sign on a MRI head that would be seen in a prion disease, that is variant Creutzfeldt-Jakob disease. Identify the ECG given in the figure below. There are four choices given. First option is normal sinus rhythm. For normal sinus rhythm, I need to identify the P waves. Now, if you try to identify the P waves in the patient, you will not be successful because you can see this twitching activity that is present. You will notice that there's a twitching activity that is present in this particular area of the recording. P waves cannot be identified. Let's calculate the heart rate. I'm able to count in this patient 1, 2, about something like 3 large squares. But then you will notice that the RR interval of the patient on a visual representation is changing. You can see here, RR interval of the patient is changing. So the highlight of this recording is an irregular RR interval. An irregular RR interval is always diagnostic of atrial fibrillation. How did I come to diagnosis of atrial fibrillation here? One, I notice irregular RR interval. Second, I notice the P wave in the ECG of the patient is absent. These are two important diagnostic criteria for the commonest arrhythmia in clinical practice. That's why the answer is atrial fibrillation. QRS complex in this patient is of normal duration. QRS complex is usually normal to reduced in patients who are having atrial fibrillation. So even that is fine by me because QRS complex is broad complex in ventricular tachycardia. So I am ruling out any possibility of VT in this patient because there is no broad complex QRS. I would suggest you that in the exam, you should calculate the RR interval at least more than once, at least thrice. Especially the lead that is recommended is lead 2 or even lead V5 if it is given. And therefore, if you are going to evaluate the RR interval, you would be in a position to identify atrial fibrillation. Otherwise, it's like hunting for a needle in a haystack. The most common arrhythmia in clinical practice is atrial fibrillation. If you compare that with flutter will be showing findings only in lead 2 and lead 3 and lead number AVF, whereas in atrial fibrillation, all leads will be showing the findings. In atrial flutter, you will be having sawtooth waves followed by a narrow QRS complex, then again sawtooth waves, then again a QRS complex. So this sawtooth pattern is the one which you need to identify, and sometimes you might see more than 2 abnormal looking waves also because the number of impulses coming from the ectopic focus can change. Therefore, atrial fibrillation and atrial flutter have to be identified. In this case, he mentions a hypertension patient. He is presented to you with complaints of palpitations and pre-syncope. You see, whenever the heart will beat fast, the fast beating heart will result in decrease in the duration of diastole. And if you decrease the duration of diastole, then the amount of blood that will fill in the ventricles will be lesser and therefore stroke volume will be lesser. That is why there is a pre-syncope. On examination, however, when he has come to the hospital, his heart rate is 72 and BP is 150 by 100. So he is a hypertensive patient. He had these complaints at home. Now when you are evaluating this patient, you are noticing the fact that in the ECG of the patient, you can see this characteristic sawtooth wave pattern which is present in lead 2, which is present in lead 3 and is also present in AVF, but it is difficult to identify this kind of a pattern with respect to the remaining leads. This is because of the fact that the ectopic focus in atrial flutter is right-sided. The ectopic focus in atrial flutter is present in the cavo-tricuspid isthmus, which is the reason why when it comes to I would say atrial flutter, the findings are seen exclusively in 3 leads only. This is the ectopic focus of atrial flutter, cavo-tricuspid isthmus, whereas in atrial fibrillation, the ectopic focus is situated in the left atria of the patient. In contrast, PSVT is responsible for re-entry phenomenon. So this re-entry phenomenon occurs around the AV node of the patient. So the blue is the representation for re-entry phenomenon that is seen with respect to PSVT, paroxysmal supraventricular tachycardia. In patients who are having VT, the ectopic focus will be in the ventricles of the patient and it will not travel via the traditional fibers, it will rather have an intermyocyte conduction. This is another representation, very classical, where you can notice the sawtooth waves in the ECG of the patient. You can also notice that they are not of equal amplitude but are of varying amplitude, and you will also notice that they do not satisfy the definition of a P wave, neither the height wise, neither the duration wise criteria. So therefore we can understand the fact this is a fast beating heart. What is the heart rate of the patient? So we can just select like two large squares here, and you can see that if two large squares are separating the R and the R interval is two large squares, then the heart rate of the patient would be something like 150 per minute. So the ECG of the patient shows tachycardia and also shows abnormal looking waves which are not satisfying the definition of the P wave. So we are going to call it the sawtooth waves of atrial flutter. A patient becomes pulseless and his BP crashes after myocardial infarction. After myocardial infarction, which means that hypoxia would be the cause. One of the causes why BP can crash after MI is ventricular fibrillation. Second is ventricular tachycardia. In this particular ECG, you can see broad complex QRS. So because you can see the broad complex QRS in the patient, this broad complex QRS is diagnostic of the fact that the patient is having ventricular tachycardia. Also, you are noticing the fact that these broad complex QRS are of almost equal amplitude. So because it is equal amplitude, therefore the diagnosis will be monomorphic ventricular tachycardia in the patient. Remember the fact that if the question is asked as patient is having stable ventricular tachycardia and what is the drug of choice, then the answer for management of this patient is intravenous amiodarone. But if the question is asked as what is the management of a pulseless VT, then you will straight away have to answer as cardioversion. You will deliver DC shock to the patient. That would be 200 joules biphasic. The DC shock that will be delivered in this case would be a non-synchronized DC shock. There are only two situations where we give a non-synchronized DC shock. One is VT, that is the one that is being discussed, and second is ventricular fibrillation. However, if they ask you for polymorphic ventricular tachycardia, that is known as torsades de Puentes, then the DOC for polymorphic ventricular tachycardia should be remembered as magnesium sulfate. This is the repeat of the AIMS exam. A 25-year-old lady has presented with recurrent episodes of syncope and palpitations. You will notice the fact that in the ECG of the patient there is a narrow complex QRS, then some ST segment depression, abnormal looking wave, some ST segment depression and abnormal looking wave is present. This kind of a recording where you are continuously getting evidence of one ST depression, and second you are having hidden P waves. I'm calling it a hidden P wave because you can see that there is merging of the P and the T waves, and there is also narrow complex QRS. These three features are always diagnostic of paroxysmal supraventricular tachycardia. This would be called as AVNRT, that is AV nodal reentrant tachycardia. The key word for this particular, the key thing to be remembered for this particular question is that there is a narrow complex QRS, there is a hidden P wave, hidden because it is formed due to merging of the P and the T wave, and there is a ST segment depression. So therefore it is known as AV nodal reentrant tachycardia. This AV nodal reentrant tachycardia is due to circus movement of current around the AV node of the patient. The first line management for this would be to go in for carotid sinus massage. However, if it is a child, we will be using a face ice pack. The drug of choice for management is adenosine. You will give a 6 mg or a 12 mg push. The biggest side effect of giving adenosine to the patient would be a development of bronchospasm in the patient. If the question is asked as how do you prevent a PSVT episode, then the answer is obviously not going to be given as adenosine, but the answer would be given as verapamil for the patient. A 10-year-old child with valvular heart disease is on heart failure treatment and the ECG is shown here. Let's just trace out the ECG. This is the P wave followed by QRS complex, then is a T wave, and then it is going to be a premature ventricular contraction, and this is a hugely wide QRS complex that you can see. I'll just trace it out again. This is P, QRS, T. This is not a P, this is a T wave. I can trace it once again before you using a different color. P, QRS, and then is a T wave. And then after that, what you are noticing is that the patient is having, this is a broad QRS complex that he is having. This is a broad QRS complex, which can also be called as a premature ventricular contraction. And prior to this is present normal sinus rhythm. So we are having alternative. What is happening here is there is a normal sinus rhythm, then there is gonna be a premature ventricular contraction occurring in a patient. So there is an alternative NSR PVC occurring in a patient. Just for similarity, I'll just use colors like this. This would be PVC. This would be normal sinus rhythm, PQRST. So what we are getting in the ECG of the patient is normal sinus rhythm and a premature ventricular contraction sequentially, alternatively every time. So this would be called as ventricular bigeminy. Ventricular bigeminy is the commonest arrhythmia of digoxin toxicity because it mentioned valvular heart disease. So therefore you can understand the question would have been on digoxin. The most common arrhythmia with digoxin toxicity should be remembered as VB, ventricular bigeminy. The drug of choice for ventricular bigeminy should be answered as lignocaine. In ventricular bigeminy, you will have a normal sinus rhythm followed by a premature ventricular contraction, a normal sinus rhythm, and then a premature ventricular contraction in a patient. So this would be a ventricular bigeminy, and this is the biggest side effect with digoxin toxicity if the values go more than 2 nanogram per deciliter. I mean, here you will have to give DG band to the patient. A 65-year-old pensioner in a ESI dispensary is complaining of exercise intolerance. So this is a geriatric age patient and he's having exercise intolerance. On auscultation, a systolic murmur grade 3 is heard. Systolic murmur is seen in valvular lesions which are of obstructive nature. Systolic. So this patient is either having pulmonic stenosis or aortic stenosis. Considering the age of the patient, this looks like aortic stenosis in a patient, because systolic murmurs are always seen with outflow obstructions. So since the patient is having valvular aortic stenosis, he could be having is a left ventricular hypertrophy. Though I can solve the question just on clinical grounds also, but we can look at the criteria for diagnosis. Though in this case, I can say that you will notice that the S wave of the patient is fairly dramatically big, and the R waves are also very big. In V5, if you look at R wave, it's fairly a decently big R wave, and the S wave in V1 is relatively deeper, but clinically we can work this out to be aortic stenosis. Remember the fact that voltage criteria for left ventricular hypertrophy is that the depth of the S wave in V1 and the height of the R wave in V5, they should be more than 35 millimeter. Now there definitely can be a bias, because if you go through the previous recordings, like I have mentioned here before you, they sometimes what happens is that the recordings might not be very diagnostic. Though in this patient there is a relatively deep S wave in lead number V1, since in the image there is overlapping in between V1 and V2, it is little difficult to appreciate the deep S wave present here. It's little difficult to appreciate the deep S wave present here, but this is a substantially deep S wave in V1 and a pretty tall R wave as compared to V6. You see, normally I can put it like this: R wave is taller in V6 as compared to V5. Here it is taller. and V4 again it's just spiraling out of control. So this is diagnostic of left ventricular hypertrophy.